I'm Tom Lüscher. I'm professor of cardiology at the University and University Hospital in Zurich, Switzerland. We're talking about myocardial infarction in our module, and today we focus on the outcome after an acute coronary syndrome, which is the overall expression for different forms of acute myocardial infarction. Now, when a patient comes to the hospital, he goes to the emergency room, then to a chest pain unit if available, and eventually in the catheterization laboratory and in the coronary care unit. So this is what happens within the hospital with the flow of the patient. Now, what is the outcome of a patient entering a hospital? Well, first of all, he will get all the drugs to make sure that the result achieved by percutaneous coronary intervention will also sustain. And that is aspirin, a P2Y12 inhibitor that also is a platelet inhibitor, a statin to reduce cholesterol, an ACE inhibitor to prevent any enlargement or remodeling of the left ventricle after myocardial infarction. And some actually need other drugs as well. Those with arrhythmias, beta blockers, those with high blood pressure, antihypertensives, the diabetics, of course, need antidiabetics, possibly insulin, and other drugs as well. What is the in-hospital mortality today? When Eisenhower had his heart attack in 1955, it was more than 50%. Today, overall, about 1 in 20 patients is dying. Overall, of course, the mortality rate, as you can see in ACS total, is the highest. If patients with a shock are excluded and only patients that come with normal hemodynamics are considered, mortality is much, much reduced. Patients who didn't require any cardiopulmonary resuscitation have even a better outcome, and if you have no CPR and no shock, no major complications, the event rate is extremely low, and 1 only in 20 patients is dying. So a simple ACS, like unstable angina, has an even lower mortality. So in summary, we can say that the mortality in acute coronary syndromes depends a lot on the initial presentation, whether the patient had an experienced sudden death, was resuscitated, whether he has pump failure due to a large infarction, and of course the quality of CPR in those who drop dead outside the hospital. Now, why do patients die if they're in the hospital and have an acute myocardial infarction? Interestingly, actually almost a third dies because of hypoxic brain damage. They have such a strong damage of the brain that they don't wake up and die eventually of aspiration pneumonia. Patients with cardiogenic shock, obviously if the heart is not able to sustain the cardiovascular system, is a mortality cause. Palliative situations, when we decide not to go further in a particular patient because of comorbidities. Some die of stroke. Ventricular rupture is getting rarer these days. Bleeding can be a cause, but fortunately has become quite rare during modern management. Now here you see the in-hospital clinical events that occur in patients with STEMI, with non-STEMI, or those with unstable angina, abbreviated UA in this very instance. And you can see that many patients have re-interventions, they have further infarctions, and it depends really on the presentation. Patients with unstable angina most frequently eventually have an intervention, while the other two groups obviously have it already at the very beginning, and they die of all the causes that I just indicated, but many of them also have additional cardiac events. One of the events that is important is bleeding, and you can see the incidence of bleeding after PCI increases over many months, and the reason is that these patients receive antithrombotic drugs such as aspirin and P2Y12 inhibitors such as clopidogrel, prasugrel or ticagrelor. And the most common site of bleeding is the groin, and therefore many centers now use the radial approach to treat patients with acute coronary syndromes to avoid bleeding. Now, once patients are out of the hospital, they commonly go to cardiac rehabilitation, either on an outpatient setting or in a rehabilitation clinic. And after 3 to 6 weeks, they go back home, and after a while, they usually resume work and are back at work. So what happens once they are back in normal life? MACE, or major adverse cardiac events at follow-up, are very common, and one of the most dangerous one is stent thrombosis, which occurs in 1 in 100 patients. As shown here, where you see at the arrow, there is a fine stent, and it's completely occluded by a thrombosis that occludes the left anterior coronary artery, where you only see the stump. There are many causes of stent thrombosis. One is, of course, the patient itself, like diabetics have more stent thrombosis, patients with acute coronary syndromes have more stent thrombosis. The stent itself, bioresorbable stents or scaffolds, have more stent thrombosis than the classical bare metal stents. And of course also the procedure itself is important. Here you see an optical coherence tomography of a stent thrombosis. On the top left corner you see a bioabsorbable stent, and you can appreciate the thrombus formation at the site of the vessel wall that eventually led to occlusion, and now with the wire being pushed through the thrombus you can see the wire and the OCT catheter. The sizing of the stent is important. On the right top panel you can see that the stent has been too small, and that leads to stent thrombosis. Then the underexpansion of a stent on the lower right corner is an important cause. And after a while, after a year or two, new plaques can form, so-called neoatherosclerosis within the stent. Thus, stenting should be performed optimally with the right stent size, high pressure implantation. No bioabsorbable stents should be used at this point in time, and optimal secondary prevention is crucial. You can see here that in large trials, the event rate after an acute coronary syndrome is quite substantial and averages 10% at 1 year. In the Plateau trial, 1 in 10 patients had some event like an infarction, stroke, or death, or rehospitalization for heart failure. In the Pegasus trial that started a couple months after an acute coronary syndrome, the event rate was a bit lower, but you can see that up to 3 years there's a continuous increase in events, demonstrating that patients are not cured after effective modern guideline-based treatment of an acute coronary syndrome, but continue to have events that have to be managed. Thus, after an acute coronary syndrome, the survivors of the event are at continued cardiovascular risk for reinfarction, stent thrombosis, stroke, heart failure, and death. Some groups are particularly prone to major cardiovascular events, such as the diabetics. You see here in the Pegasus trial, those with and without diabetes, those without diabetes in the dotted lines have a much lower event rate than those who have diabetes, no matter whether they have clopidogrel or ticagrelor as antithrombotic treatment. Also, patients with renal failure have a much higher event rate after an acute coronary syndrome, as you can see in the top 2 lines that refer to those treated with ticagrelor or clopidogrel respectively, compared to those who have no renal failure, where the 2 drugs have more or less the same event rate. So the question is, if thrombosis, infarction and stroke are an important cause of events after an acute myocardial infarction, how long should we use dual antiplatelet therapy, or DAPT? That is aspirin plus a P2Y12 inhibitor. Well, we could say forever, because we want to avoid stent thrombosis or a new occlusion, a new infarction. But of course, dual antiplatelet therapy increases the risk of bleeding, as shown here in the stomach, with a severe arterial bleeding that can also threaten the life of a patient. So we have to consider both the ischemic risk of a patient and the bleeding risk. Bleeding risk increases with age when they take non-steroidal anti-inflammatory drugs or have a history of gastrointestinal bleeding. The ischemic risk is the higher, the more vessels are involved. 3-vessel coronary artery disease has a higher ischemic risk than a single coronary artery disease, and this has to be balanced by an experienced physician. But what is important in the next graph is that the events are as common in the stented region as they are in the regions of the coronary circulation outside the occlusion where no stent has been placed, and this demonstrates clearly that atherosclerosis is a progressive disease in nature, and therefore new plaque formation has to be avoided under all circumstances. So the atherosclerosis process is progressive in nature, and thus patients with an ACS continue to develop new plaques that are causing further MACE, such as infarction and death. And besides statins that are common practice today and lower cholesterol substantially in those that do not reach appropriate target levels of cholesterol or LDL cholesterol in particular, such as 1.8 millimoles per liter, they should be considered for PCSK9 inhibition. PCSK9 is a protein that's released from hepatocytes and degrades LDL receptors, leading to higher LDL levels. Now, if you give an PCSK9 inhibitor to a patient, such as shown in this GLAGO trial, you can reduce LDL cholesterol substantially further. This drug has to be applied subcutaneously by injection twice weekly. And what's important in this GLAGO trial, you can see here the reduction in plaque formation as assessed by intravascular ultrasound, and you can see once you reach a level of LDL cholesterol of 1.4 or lower, there is actually a regression. That means that the plaque becomes smaller, is below the zero line on the slide, and this provides regression of atherosclerosis, and therefore further events should be avoided under these conditions. And indeed, a recent large trial with more than 20,000 patients with a PCSK9 inhibitor, evolocumab in this instance, has shown in the Fourier trial that the event rate is further reduced when we lower cholesterol further by a couple %. So in summary, we can say that ACS remains a condition with high morbidity and mortality. Optimal guideline-based management is crucial. In spite of optimal management in hospital, mortality remains at 5% overall, particularly in those that have undergone cardiopulmonary resuscitation or present in cardiogenic shock. Events continue to accumulate after ACS at the rate of 10% in the first year and continue to accumulate further thereafter. Thus, secondary prevention with further lowering of LDL cholesterol, but also normalization of blood pressure and plasma glucose, among others, have to be improved to the benefit of our patients. I'll thank you for your attention.